Hello, everyone, and thank you for joining us for today's webinar, CMS Ramps Up Scrutiny on Improper Payments, What Plans Need to Know. Before we begin, I'll walk us through a few quick housekeeping instructions. We will begin today's webinar with a discussion, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have issues with audio or visuals, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I am pleased to introduce today's speakers, Cereasa Horner, Director of Policy and Payment Integrity at CERIS, Stephen Hamilton, Partner at Crowell and Mooring, and Payal Nanavati, Counsel at Crowell and Mooring. Thank you, Payal, Stephen, and Cereasa for being here today. I'll now turn the floor over to you to get us started.
Thank you all for having us. My name is Cereasa Horner. I'm the Director of Policy and Payment Integrity at CERIS. I have been in the healthcare industry for around 20 years, first starting in revenue integrity and then transitioning over to payment integrity with CERIS. At CERIS, I oversee all of our back-end processes and our payment integrity team through appeals, customer service, and also our internal audit process. I'll turn it over to Stephen for him to introduce himself.
Thanks, Teresa. I'm Steve Hamilton. I'm a partner in Chicago at Crowell and Mooring. Just came over here a few months ago, and I've worked in the managed care industry with health plans for almost 20 years now, with a particular focus on representing government-sponsored health plans, so generally Medicare Advantage, Part D, Medicaid managed care, and really all things regulatory compliance, litigation, and government enforcement actions. So really looking forward to discussing this topic with you. It's a very hot topic and very excited, so thank you. Turn it over to Payal.
Thanks, Steve. My name's Payal Nanavati. My practice focuses on helping healthcare entities that participate in federal or state healthcare programs, especially those facing audits and inquiries from the government, especially lately helping those facing RADV audits or preparing for RADV audits. But in general, my practice involves advising and advocating for entities in the healthcare industry facing government investigations or high-stakes litigation with a particular focus on False Claims Act matters. I'm looking forward to our discussion.
Great. Well, thanks, everyone. I think we're going to jump off, and we're here to talk about CMS's ramping up its scrutiny on improper payment of health plans. And we want to start out by level setting, I think, as to what we're really talking about. When we discuss scrutiny, we're really talking about government enforcement actions and audits. And we've seen a significant increase in this activity over the past few years. Even compared to just 5 years ago, the government activity has just ramped up significantly. A key example of that is the increased enforcement by the current administration and its prioritization of Medicare Advantage risk adjustment and RADV audits. I'm sure if you're on this, you know what risk adjustment is, but just if you don't, risk adjustment is the process by which Medicare Advantage plans are paid varying amounts depending on the medical complexity of the member, as determined essentially by diagnosis codes. Ultimately, how it works is plans submit diagnosis codes through encounter data. Those diagnosis codes, for the most part, come from providers. The vast majority of them come from providers. And then CMS takes those diagnosis codes, rolls them up into what are called hierarchical condition categories, or HCCs. And those HCCs purport to reflect the medical complexity of the member. The RADV audit, and one of the key, like we said, enforcement priorities, is CMS's primary method to determine whether or not the risk adjustment payments have been properly made. So what CMS does is it's allowed to conduct these RADV audits, and they do it every year, and they've done it for years. But reason why we're talking about it now is because the world has changed significantly in the past 2 years in this subject. It started well, it started a while ago, but it came to fruition really in 2023 when CMS changed its rules to allow extrapolated RADV audits. And that was a huge change from prior practice where CMS was conducting RADV audits on a set of all the Medicare Advantage contracts out there. So, they did somewhere between maybe 40 and 60 contracts in prior years. And when they did that, they were doing it strictly on what I'll call a hard audit. So they would take a look at a certain number of HCCs and then determine what the purported overpayment was for those HCCs and recover those hard dollars from the plans. But in 2023, CMS said we were now permitted to extrapolate the results of that. And really that was had a potential for significant financial impacts on plans. What CMS did too is determine that they're only going to do those extrapolated audits starting in contract year 2018 and later. So those contract year 2018 audits started in earnest last year, this past year, and we're now going forward. There's been two other significant events that's changed this too. In May of 2025, CMS said not only are we going to do extrapolated audits, we're now going to do what we call all contracts. So CMS announced from a policy position that instead of just doing a subset of the contracts in the world, it is now going to do all MAO contracts out there. So it went from somewhere around 40 to 60 to 400 to 450 audits. That too was a huge policy change and a big shift. And CMS did that literally through an announcement as opposed to formal notice and comment rulemaking. And then about 2 weeks ago, we had this all thrown into chaos further when a district court in Texas ruled as a result of a challenge brought by Humana that the 2023 rule was improperly implemented by CMS and that CMS didn't properly follow the procedural requirements that were necessary to implement that rule. So that district court vacated the 2023 rule, which was the rule that formally implemented extrapolation and CMS's authority to implement extrapolation. So here we are today. We were talking about this in advance of the webinar about how, at any minute the world could change again, and we don't know what CMS is going to do. But right now, as we sit here, the RADV audits that were underway are still going forward. We just don't know what's going to happen to them and what position CMS is going to take. So getting back to level setting, we're here because of the scrutiny that the government has put on plans. RADV is probably the primary scrutiny that we're all talking about, but there's other examples too. You have your medical loss ratio audits by states. You have your financial audits. Once they're financial audits, you have your program audits. But RADV is really where the meat and potato is right now. All right. I think I'm going to turn this over to Payal. Payal, do you want to talk about some of with the heightened scrutiny, how can payers modernize and update their compliance infrastructure?
Yeah, sure. Thank you, Steve. So many of our clients are asking us this very question, and we think it's a very smart question to ask. Basically, how can I prepare for this increased scrutiny from the government? And the key message here is really that payers should be proactive instead of reactive. And that's because of something you just covered, which is that it's fairly certain that audits are coming, right? With federal and state healthcare programs, audits and inquiries from the government are not a matter of if, but when. So in that light, I think there's a couple of points we want to make in terms of improving compliance infrastructure. So first, it is important to set a legal strategy at the outset of audit responses and activities. So essentially, the audit request you receive today can have major legal impacts for your company in the future, and your legal team can help you understand those legal and financial risks of adverse findings. To illustrate, we've seen referrals of unfavorable CMS and OIG audit results to the Department of Justice for evaluation of a False Claims Act investigation. And we understand this is kind of a routine referral process that is undertaken, but this is when the results of an audit can be converted into allegations of knowingly submitting false claims to the government. So this is a big risk. Companies probably know that you'd be subject to treble damages and penalties, not to mention the costly expenses to defend against a DOJ investigation. So as someone who plays in this space and counsels clients who are facing that ultimate DOJ inquiry or investigation, I think it's fair to say that it's just better to have that legal strategy at the outset so that you can really be aware of what might be coming down the road as you're responding to a more routine government request. Things can escalate fast, and you want to know and be prepared for that. Second, and more practically speaking, the certainty of audits means that compliance and legal teams should be assessing and identifying areas for improvement. We've seen issues bubble up for our clients in the context of audits of plans processes that lead to payment by the government. So, the holistic process that could lead to an improper payment from the government, that is where you need to be focusing on your compliance infrastructure to make sure that you're aware of those processes and how they can be bolstered. So some examples of that would be oversight and monitoring of your vendors who are involved in those processes. You have to ensure that you are doing your diligence on those vendors, but also monitoring them on the back end as they perform for you. So you need to make sure that you're exercising your rights to audit them to ensure that they are performing up to your standards. Second thing is reviewing and staying up to date on internal guidelines and policies. So your own internal guidelines and policies, those might apply to your vendors, but they should at least be up to your standards internally. One example of this that we've spoken about before is your risk adjustment coding guidelines. That is something that needs to be updated based not only on, the ICD guidelines or the coding clinic guidelines that CMS has incorporated into its regulations, but it should also be updated based on your own results of audits. So if you receive an audit and you get results of that audit, you should be looking at what the takeaways are from the agency. Where were you not performing or meeting their standards, and where were you? And you can take a look at your guidelines and make sure that they are actually, meeting those standards going forward. And then the third area is provider education. We think this is somewhere where plans can really improve their processes and make sure that everyone in the healthcare delivery system is more aware of how the information that they submit to you can be submitted to the government and the impacts of that submission to the government. And so just making sure that folks are aware of where their codes and their claims go so that they're aware of how what they do fits into this bigger puzzle here. So these can be tricky items that seem to be somewhat in the periphery sometimes, but we think proactive thinking here can really help get you ahead of these issues coming down the road.
I agree with you, Payal. You touched on a few points that kind of rule my day to day, I would say. And as providers and payers are preparing for those CMS audits, as you stated, it's not if it's going to happen, it's when is it going to happen. And preparing for those audits, it really does start in your day-to-day processes and your policies and how you're actually enforcing those. And so one of the things that is really important, I would say for you and Stephen, when you guys are having those conversations, is what documentation is available? How have you reviewed that documentation, and what have you done in preparation for your providers to be aware? And one of the first things that you want to make sure that you do is that you create policy and make sure that that policy fully explains what the expectation is in that documentation. That goes not only around coding and unbundling, but also since you're going to be dealing with medical records and providers submitting that type of documentation, you want to make sure that you're setting parameters around what they should actually be submitting, signatures being required, and what you expect to see in that medical record, and making sure that if a provider is submitting that information, that they are submitting it timely and not going through and kind of changing that on the back end. And so when that documentation is not there, that can be one of the triggers for those type of audits with CMS. And one of the things that you can do, a lot of times as a payer, you're looking at reporting on the back end once the claim has been completed, and you're looking at your findings and you are comparing that against your audit results. One of the ways that you could be proactive is to look at providers who are consistently submitting that additional documentation that's going to change the outcome of that claim. That allows you to couple your policy enforcement along with that provider education, and allows a targeted focus to make sure that providers are submitting that correct information on the front end, rather than when they've received a claim denial or even an audit request. It makes the process a lot smoother to do it on the front end. I'd also say that in creating your policies and doing the provider education, you also want to make sure that you have appropriate internal audits and you are monitoring your claims and the coding in real time. So you don't want to let 3 months pass or 6 months or even a year and a problem has been occurring and it has not been addressed. That is really valuable time lost in multiple instances. One, you have providers who are billing and being reimbursed correctly, and it also takes time away from your internal teams who are creating those policies or implementing those internal policies to be created and implemented. And so when you are creating those internal audits, there's a few things that you want to make sure that you are incorporating into that. One are coding edits. We know that modifier usage, or modifier misusage rather, is something that occurs quite frequently on claims. So you want to make sure that you have coding edits in place that address that. And also, if there is misuse or mismatch of the diagnosis codes and procedure codes, those are quick and easy common errors that you all can catch that are pretty straightforward, no matter who the provider is. And you also want to make sure that you have internal feedback loops. So you want to make sure that essentially the right hand knows what the left hand is doing. And so if you are creating policies, making sure that you are communicating with your IT and your claims team so that when those edits are in place, they are aware, and you all can set internal protocols. So if those edits are not firing, you're able to catch that and correct that. I would also say that consistency is key all the way around, whether you're implementing policy, coding edits, or reviewing documentation. So you want to make sure that those protocols are outlined to where your frontline employees actually understand that information and can uniformly apply it to all of the claims that they're reviewing. And then on the back end, when you are getting those audit requests and those findings, you already have defined processes that you can share and show that, hey, we have been proactive, we've implemented this, or we identified this error, and then we also did provider education with that. And so, Payal, I know that you guys are working closely with providers. How are you guys seeing that documentation affect your strategy when you're having those conversations?
Yeah, sure. So provider documentation is one of the most important things, especially when you're thinking about risk adjustment. At the end of the day, that is what the coding is supported based on or not. And so we found that plans, have limited ability to impact providers' medical records, but they can educate providers about why it's so important and what is so important about medical records. I think that's a really important thing that plans can do to make sure they're getting ahead of potential audits or inquiries when they're talking to their providers about how to make sure that they are meeting their obligations as well.
That's very true. And I think from a payer perspective, it can be very resource intensive to conduct those audits because you have to staff for that internally. And you also have to make sure that your staff has the experience to be able to address those things internally, but also when you get those audit findings. And I would say, when you are looking at how you can be smarter and faster and more efficient with resource intensive audits, AI is always going to be a tool for that. Now, AI, I always say, is a double-edged sword because as much as payers are using it, providers are also using it too. And when you're talking about the risk adjustment audits and providers using that on the front end, it's a great tool to be able to look through the record quickly, code it, and get the claim out the door. But one of the pitfalls that payers should really be looking at when it comes to that is that AI typically cannot determine when they're looking at that medical record whether a patient's medical condition that's reported in the history is, 10 years in the past. Is it a chronic condition? And does that history currently impact their patient encounter for that particular episode? And so because AI cannot readily identify that or accurately identify that just yet, that is something that payers want to make sure that they have in their internal audits when they are reviewing these records. I'd also say that you want to make sure that your team is educated. Here at CERIS, we make sure to have a really diverse team that's worked on the payer side and the provider side because they're able to see things from both aspects, right? And I'd also say that, when CMS is, giving out these mandates and audits, sometimes they can also be a bit ambiguous. Sometimes CMS typically lives in the gray. And so Stephen, how do you all counsel clients when CMS is sometimes gray and that could potentially lead to your clients being non-compliant?
Yeah, sure. That's where we live too. Our clients come to us when the issues are gray. Of course, if they're black and white, the clients handle those themselves. So Payal and I live day to day in the gray. And how we do that really is to start by just getting the best understanding of what the regulatory framework is from both the obviously the rules, the regulations, but also whatever guidance is out there so that we can identify where the boundaries are and then what falls within that gray. And then when we assess the issues, we look at how is our client acting within that gray and what can we do to mitigate risk. So if you look at any scenario and you say there's 10 levers or 10 factors that we're looking at, can we tweak 3 of these factors to reduce the risk so that the client can operate in a way that is the least risky while still advancing business goals? So that's generally how we look at it.
I think that it's important when you're really assessing that risk because sometimes there isn't a complete 100% right or wrong way to do some things. And so you're really basically taking, those policies that CMS is issuing and charting the best course of action. And when you're doing that, even though, we kind of talked about the Humana decision earlier and the risk adjustment audits, they are still going to come. And so the expectation is still for those payers to have processes in place that address those risks. And so we talked a little bit about AI and having your staff and having your internal policies. And that really starts with cumulatively looking at what the process is from start to finish and getting those key players all in the same room and having a discussion and identifying what your goals are, where you already have identified the gaps before you enlist a Payal or a Stephen in your processes so that they can best help you with that. One of the ways to be able to do that is also to enlist a vendor. And as Payal shared earlier, when you're working with a vendor, it is very important to make sure that you do have oversight over that. And that part is making sure that what your vendor is doing is consistent with what your guidelines are and what your expectations are. And that starts with conversations in the beginning, during implementation, and then also once you have gone live as well. And so that oversight comes through reporting and identifying what data points you need in order for your vendor to be successful, and then also what you all are needing for your reporting on the back end. And so, Paul, I'll turn it over to you to talk about a few more things that payers can actually do today.
Yeah, sure. One thing that we wanted to talk about was legal defenses or mitigation strategies that payers should be aware of when they're responding to overpayment findings or RADV audit outcomes. So just quickly, I'll talk about a few of these things. Payers should be aware of strategies and defenses that are kind of included in this concept of administrative law. So when you're facing an audit or an inquiry from a federal agency or a state agency, there are these principles that you follow as well as the agency follows, and that's from this concept of administrative law. So one of those principles is exhaustion. And what that means is that entities who are facing these inquiries have to exhaust their administrative appeals before they can seek their redress in court. Another admin law concept is about evidence. So in those administrative appeals, before you can even get to court, you have to, each step of the appeal will likely be based only on the record that has been built so far. So there's this restriction on introducing new evidence at subsequent stages. All of that background leads to a practical suggestion for folks who are facing audits and inquiries. And that's essentially to pursue their appeal opportunities and other avenues that can help them build the record. So one example that has come up a lot recently is in the RADV audit context. So we've been counseling clients on how to navigate that process. It's very rigid. CMS has rules about how you can appeal and what you can appeal. But what we think is that it's generally better to submit things like hardship exception requests. Even if it looks like you're going to be able to get your medical records in time, it's better to reserve those rights and those arguments and put the agency on notice of potential hardships, even if you're not sure you're going to need to rely on those arguments. It's something that we feel could be important down the line if you're facing unfavorable audit results. One other thing in the category of legal defenses is that people probably think like, okay, I want to challenge the methodology that's being applied to me. This is something that comes up a lot. And I think what is important to note here is that you should definitely challenge the methodology when you have an opportunity to do so. But there have been limits that have been set by agencies about when you can challenge the methodology. And it may be that as part of your appeal, like for RADV audits, there's limitations placed on how much you can challenge the methodology. And so in those situations, it's really important to think about whether your challenge is about the methodology or about something else. And how can you make the argument that it's about something broader than just the methodology and how it's been applied to you. So that is something that we talk to our clients about a lot. We've had some success, especially in the fee-for-service audits, but it is something to be thinking about when you're thinking about forward-looking strategy. I wonder if now we should turn to, I think one of the questions we wanted to talk about, Steve, was the legal implications for our clients of non-compliance, especially in light of CMS's tighter rules around diagnosis coding and chart reviews. What does that mean for our clients?
Yeah, sure. Happy to talk about that. Thanks, pal. So the legal implications of non-compliance with any audit can be varied, sometimes extensive, sometimes not. When we talk about RAV audits, again, that is a little bit in the air right now, but let's assume for a minute that some type of RAV audit will continue on an extrapolated basis. In that case, the legal implications can be pretty extensive. And when I talk about legal, I mean the audit findings themselves will, and Payal, you touched upon the appeals and the challenges that may arise from those appeals and post appeals. But the legal implications there are pretty extensive, as well as the financial implications on an extrapolated audit. If you kind of use an example, if you have an MAO with 1,000 members and there's a RADV audit with a sample size of 60 members and maybe 1,000 HCCs or something, CMS is going to audit the records for those 60 members, and just one or two or three findings of noncompliance with the diagnosis codes alone on an extrapolated basis can have an outsized impact. For instance, if you had a 10% error rate on the sample back in prior times, that wouldn't be a significant recovery, right? It may be a couple $100,000. Now that's going to be extrapolated. If you used our 100,000 member contract as an example, that'll be extrapolated off a significant portion of that population, resulting in possibly tens of millions of dollars of financial impact. So it's going to be huge. Another example of potential legal ramifications, and Payal, you touched upon this, was the migration of the audit to the FCA world and the issues that arise there. And as we all know, MAOs have been targets of the Department of Justice and whistleblowers with respect to risk adjustment. These audit findings can come into play not just to potentially create a theory, but also come into play with respect to narratives regarding existing cases as well. So these financial implications aren't the only thing. There are possible legal implications as well. And really, at the end of the day, it's really important for plans to take the proactive risk mitigation measures that you were talking about, Payal, to try to reduce as much risk as possible, not just for the audit, but for these tail legal consequences. So very important stuff. I think, when we look forward to the future, we don't know what that future will bring, but we can be pretty certain it's going to continue to have some level of auditing. It's just a matter of the details around the auditing. And we need to all continue to really focus on this. And Cereasa, I thought I would maybe ask you, what is it that CMS is looking for now as we kind of look forward into the future, and how do you help clients address those issues?
Yeah, I really think that they are looking for consistency across that documentation. And as you shared, 2 or 3 findings can have a significant impact. And so as a payer, you really have to make sure that you have all of your processes and your documentation in place to be able to avoid those adverse determinations. As a vendor, it is a different place to be in, I would say, especially with a lot of the ambiguity that is out there around risk adjustment audits and the changes that CMS is making. But one of the best ways to be a partner is to be able to adapt quickly and be able to help our clients adapt quickly as well. And so that really starts with building that infrastructure of staying abreast of what CMS is currently doing, partnership with firms like you all that have vast experience in the space and can be able to provide a legal perspective and then being able to implement what the strategy is. And that is not something that should start 6 months from now or even a year now, maybe when a new decision comes. That truly happens today, with that vendor partnership, implementing those internal policies and processes to be proactive. For that, because you can always adapt and change a policy in the future, but you don't want to be 3 years behind the game, especially if you know that there is potentially going to be a look back period from CMS when they do fully implement that ramp up on RADV audits as well.
Yeah, thanks, Cereasa. And I think you raise a good point. You know, what can providers do with respect to particularly RADV audits? Because as we talked about, providers play a foundational role in RADV. The vast majority of diagnosis codes are coming from provider claims data. So it's really important that providers adopt some of the same compliance and proactive infrastructure, similar to what Payal talked about earlier, to try to not just get the best data, but to mitigate the risk, because the risk can potentially flow down to the providers as well. We've seen cases against not just plans, but downstream providers in the FCA world. And that's probably not the end of that theory, right? So providers have to, as much as plans, providers have to really adopt some of these same measures. And I think as we go forward, there's going to be a lot more probably cooperation, sometimes non-cooperation between plans and providers because of the burden that this is going to place on providers as well, as CMS has moved into this new world of all contracts, if that's where they end up, and extrapolated audit findings.
I agree with you wholeheartedly.
With that, Cereasa and Payal, should we move into the Q&A session?
I think we should.
Right.
Let's see if we have questions.
Yeah, well, thank you, Payal, Stephen, and Cereasa for a wonderful discussion today. We'll now begin today's Q&A session. So audience, as a reminder, please feel free to submit your questions via the Q&A box on your screen. With that, let's get started with the first question, which is, with the current changes in CMS and the policy changes that you've discussed, could each of you share what you think the most important things payers and providers should be focused on?
I will say I'll piggyback off of what Stephen just said, cooperation and collaboration, because those are the only two things that will be able to help both sides get on the other side of that mountain. Typically, when there are new policies that are implemented, especially from a payer perspective, there can be a bit of hesitation because they don't want to have that provider abrasion. But provider abrasion is going to be natural. And the way that you have helped mitigate that abrasion is by doing provider education and also making sure that your policies are very clear and consistent with industry standards. So you don't want to be the payer with the policy that's an anomaly and very inconsistent or very vague. You want to be as specific as you can be. And you also want to allow time for your providers to prepare for the impact of what that policy can be. So just on the payer side, as it's resource intensive, it is also resource intensive on the provider side as well. And so again, that collaboration between the two and that education, it helps level set expectations on both parts. And it also, quite honestly, provides a feedback loop. And so if you are a payer and you are staying in touch through your network reps with your providers, you're able to hear what that feedback is, understand what the capabilities are of your providers. And if they are implementing those compliance standards, it may take them 6 months to implement some of the data points that you are needing to effectively implement your own internal strategy. So making sure that you're keeping that in mind and keeping that line of communication open for collaboration as well.
Yeah, and I'll just reemphasize something I said at the outset, which is that entities that think they're going to be subject to audits should have a proactive stance for compliance so that when those audits come, the entire team is ready. Right now is a good time to do that if you would be subject to RADV audits. There is some uncertainty about the timing, and like Steve said, there's some uncertainty about how it's going to look. But one thing's for sure, we're going to see audits at some point. So it's a good time to get your ducks in a row and start thinking through those issues. Just two more specific points is thinking proactively about compliance sometimes involves internal reviews of your program. So having time to evaluate your own compliance program in the context of risk adjustment or claim submission or whatever it may be can be important. And then number two is if you are in a compliance or legal role, it is very imperative that you have a close collaboration with your own team, the teams that are implementing some of these processes internally. Your risk adjustment team, I bet they're extremely knowledgeable and they are up to date on what's going on. But it's important for you to also be someone they can turn to with questions and also to help them think through the bigger picture here so that the company can be prepared for what's coming. Steve, I'll pass it to you.
Yeah, thanks, Pal. I think the final thing, we touched on a lot. The final thing I would say is that the time is ripe for press, collaboration with CMS. And I won't call it lobbying because it's not per se lobbying, but trying to engage the agency with respect to any audit, particularly RADV. As we talked about several times now, the landscape is uncertain, and CMS has to deal with that as well. They need to come up with a solution right now to comply with the court order. And when that happens, and anytime when that happens, CMS often has its ears open. Case in point, this week, Administrator Oz was speaking at a health policy conference in Washington, and indicated that he and their agency have been open to meeting with plans and I assume providers to discuss key collaboration points that would presumably include RADV and other areas of concern for plans. So anytime that you have this time of uncertainty is yet another opportunity to engage the agency and try to help shape the policy that's going to be next.
Thank you all for your wonderful perspectives on that. The next question that we have here is, are there legal distinctions we should be aware of between unintentional coding errors and fraud under current audit scrutiny?
Yeah, thanks. I'll start with that, and I'll focus on just the RADV audit perspective. When you're dealing with a RADV audit, the intent is irrelevant, quite frankly. CMS is looking at what documentation supports the HCCs or the diagnosis codes that have been billed or coded, and whether or not that was an intentional coding or unintentional coding is not going to be part of the calculus for purposes of RADV audits. Now, that being said, we've talked about other legal risks that arise from these areas, and that includes false claims. And Payal, you live in that world. Do you want to talk about that for a second?
Yeah, sure. I'd love to. So we've mentioned this before, but the False Claims Act is one of the biggest legal risks in this space. And I think this question really allows us to dig into that a bit more. So is there a difference between unintentional coding errors and fraud? There is when you're thinking about a potential FCA violation. So under the False Claims Act, a violation requires a knowing submission of false information to the government that is material to the government's decision to pay. So, in this context, the thing to be aware of is that unintentional coding errors can turn into FCA allegations if the conduct allegedly meets a threshold of knowledge, which is actual knowledge, reckless disregard, or deliberate ignorance. So what that means is that unintentional coding errors, if there are a lot of them, or if the government feels like there's a high error rate in your coding, they can make the argument that the company has recklessly disregarded evidence or deliberately ignored evidence that they are not meeting the applicable standards. So that's important because what is an unintentional coding error on its own could collectively, with other coding errors, become an allegation of fraud. And we've seen the government take the position that, anything bigger than a 5% error rate is evidence of fraud. We have some good defenses to that, but the government is going to be very aggressive in this space when it comes to coding errors and companies' own compliance programs. So the defenses that you want to focus on is demonstrating that your risk adjustment program is operating in a way to decrease the number of unintentional coding errors. And you're able to paint kind of a holistic picture about your compliance program to show that the company was not recklessly disregarding or deliberately ignoring any issues in their coding processes. So that is a really key area when you're thinking about audit risk, is looking forward and seeing what could the implications of a high error rate be, especially when it comes to the False Claims Act, which is a huge risk for companies in this space.
Thank you all again. We've got time for one more question. So the last one we have here is, given the complexity of aligning audit readiness with CMS expectations, how can payers partner with vendors to assist in closing the gaps and provide proactive solutions before claims are submitted?
Yeah, so this is kind of what Payal was talking about, right? Those unintentional coding errors. And from a payer perspective, one of the ways that you can start mitigating that is through data analytics. So that's looking at your own claims data and the claims history of those patients and making sure that you are essentially reconciling that data to make sure that there is not incorrect coding or upcoding or even inconsistent coding across patients, because that's important as well. And then as you are working with a vendor, it is important to emphasize those data points that are needed for your reporting purposes, because if you don't have that information, it can be very hard to go and backtrack to try and put that information together, to tell that story holistically of what you have done and you have implemented in your risk adjustment processes. Paul or Stephen, any other thoughts about that question?
Yeah, the only thing I would say, Cereasa, and it aligns with what you're saying, is that it really is a partnership when it comes to risk adjustment. As we talked about, the providers have the foundational information. And to dovetail with what Payal was saying about proactive compliance and proactive infrastructure, we've seen plans starting to work with providers on the contractual basis to update contracts to ensure that there is a framework in place for responding to audits that's more than just you have to respond to an audit. It's more detailed information. So we can probably expect that to continue, particularly assuming that the risk adjustment audits are going to continue in some form or fashion with the significant consequences that they're having.
It's surely better to have more information than have none.
Exactly.
Yes.
That's all I had. Thank you very much.
Absolutely. Well, thank you all again for such a wonderful discussion today. I want to also thank CERIS for sponsoring today's webinars. Audience, thank you so much for joining us today. We hope you have a wonderful rest of your day.